Welcome. Thank you for asking me. I'm Jen McCarthy. I'm a nurse practitioner with Barbara's Health Medical Group and J Electrophysiology. I've been doing this way too long. But if you really need to know, nurse practitioner 20 years now. And in the world of electrophysiology for 25. So I guess I'm an expert at this point. I guess you would call it. So we're going to learn about pacing foundations. Please don't be alarmed by that. And how it kind of applies to your critical care setting. And then please ask any questions at any time. I forgot to put a disclosure slide in here. I do talks for Zoll. I'm in the panel for Abbott or St. Jude, and I've also done talks for Medtronic as well. So I've been on all their boards to be able to do that. These are our objectives. I'm not going to read them out loud. You can read them yourself. We're going to learn about different modes of pacing, which is probably most important for you. But what I want to start off with is review of the conduction system, right? Because if we don't know the normal electrical conduction system, we're not going to know what's abnormal and what to look for. So we focus on electricity. Come in. It's Desmond. We focus on the electricity for our group, right? But pumping and electricity go together. So if you don't have a pump, right, what do we have if there's no pumping but you have electricity? First question. Good. PEA. So, but you need both of them, right, in order for everything to function. So PA is pulseless electrical activity. So you may see an electrical signal on your telemetry monitoring, or you go in the room, or you see something on an EKG, but they have no pulse, right, and the heart's not pumping. So typically, this is the normal electrical signal, right? We have the aorta, we have the superior vena cava. The superior vena cava supplies blood to your right atrium. The right atrium then pumps. You have the sinus node that then depolarizes. And if you could see, most people think the sinus node's right in the right upper chamber, or the right atrium. But you see all those little branches? It's because it depolarizes all throughout the atrium. So it's not just sitting right there and just going from here to the AV node. We have all these little branches. So that's why there can be a lot of different arrhythmias that occur both on the right and the left side of the heart because of that. Then the sinus node, once it depolarizes, it goes to the AV node, which is, you can see the little middle portion there. Structurally, I'm sorry, I'm going to come over here. What's important here from a pumping perspective, see the AV node? It's right near the septal wall, the tricuspid valve, and the aortic valve, right? So think of your TAVRs that you guys get, why they have heart block. Because if there's a problem with conduction to your AV node, because of inflammation around the aortic valve or any surgical procedures, even if somebody does aortic root graft, that could be the reason why, because it's causing irritation, or it could cause any damage to the AV node or the branch that's going from the sinus node to the AV node. Oh, yeah.
No, it doesn't work on the TV.
It doesn't?
It goes away.
Does it? Okay. I'll kind of point. I'll try not to go around, but because I'm very I'm a moving person. I'm probably not going to, if somebody needs a chair, I'll give you my chair. I'm not going to sit. So anyway, I'm spending a lot of time on this slide. Once it goes from the AV node, right, it goes down your bundle of His, which are these branches here, and then it goes up the right and the left ventricle. So you have the right bundle branch, and then you have the left bundle. Left bundle is broken into two, posterior and anterior fascicles. So that's why you may hear anterior fascicular block or posterior fascicular block. And those fascicles go up there, and I'm going to show you a nice little video. Hopefully will this start for me? Oh no. Stinker. Oh, here, yeah. Sorry guys, I am not the most technically savvy. I was surprised I even got this in. So you can see the heart pumps, blood flows through into the heart, sinus node gets triggered, it makes the right atrium and the left atrium contract, then the signals go through the AV node down to the bundles, and it restarts all over again. So like I said, pumping and electricity all come into play. If something is off on one, it's going to affect the other. That's why pacing can be so important. I'm going to go over at the very end, just as a review, why pacing is important. So that's your overview. Any questions so far about any of this? Questions, concerns? Okay. So indications for pacing. So it's right in front of you, but off the top of your heads, why would you want to put a pacemaker in somebody? Why does critical care put pacers on people? What's a patient that you see that you put a not even implantable. I'm talking about even temporary.
Irregular heart rhythm?
Could be, yeah. TAVR patients, right, that develop heart block. So there's different classifications, right? And everything we have class 1, 2, and 3. 2 is broken into A and B. 1 means is that we have enough data or information, research studies that say, yes, this is definitive, we should be putting pacemakers in for this reason. Class 2, there's A and B. A is like there's enough data, strong enough to move forward. B is there's data, but it's questionable, depends on the patient, what's actually happening. And 3 is like, you shouldn't be putting in a device. So class 1, obviously symptomatic second or third degree AV block, junctional rhythms with symptoms, SA node disease, and of course like any types of asystole that patients might be having. Usually you can do greater than 3 seconds. And then post-op heart block, so let's just say like a TAVR patient that does not have a resolution because of a reversible cause. Class 2, you can read, this is asymptomatic heart block, resistant sinus bradycardia. You could also have first-degree heart block with greater than 300 milliseconds. Why do you think of a PR interval? So you have a P wave, but the interval's really prolonged, because normal PR interval is less than... Yeah, or 200 milliseconds. So EP talks in milliseconds or 0.02, 200 milliseconds. So if it's greater than 300 milliseconds, do you know why it may be a problem? There is a block. There's a first degree block. But you got to remember I talked about before in the beginning, I talked about electrical and pumping. So it's all about filling, right? So if you have this really prolonged filling time because it takes so long for the sinus node to conduct to the AV node, it can actually contribute to poor cardiac output and then diastolic filling and then contraction of the ventricles. Yeah, so that's another reason why it's a class 2. It's a 2B, but it's a class 2B indication that you may want to consider that because there could be improvement for the patient. And then class 3, meaning like first degree heart block, just general, is like 200, maybe 240, 260, asymptomatic sinus bradycardia. I put reversible because there's many reversible reasons. Somebody can have sinus bradycardia because they're on a lot of metoprolol. Somebody can have sinus bradycardia because they're on a high dose of cardizem, or maybe they were getting digoxin, they're digitoxic. Maybe they have significant hypothyroidism, right? So there's other factors that can contribute. We get called about sinus bradycardia all the time, and as Fran and Shipra know, we are basically detectives trying to figure out what the heck's going on with the patient, and then seeing is this something that's reversible, or do they truly need some form of pacing? And then others are carotid sinus hypersensitivity or sinus sensitivity. That's if you rub on the carotid sinus. And these are patients that they say when they turn their head side to side, they get really dizzy. It's because they wind up having asystole. That's at greater than 3 seconds. If you rub on the carotid sinus and they have these really long pauses, that could be an indication for putting a pacemaker in. Vasovagal, right? Somebody significant gets up and they just drop and their heart rate plummets. Those are the ones that we usually do tilt tests on. And then tilt tests, I'm not going to go completely into it, but it's a test to check to see if a patient's heart rate and blood pressures fluctuate with an upright position. And then, of course, transplant patients and then post-MI, which you guys will see. Okay. So would this be a reason to put a pacemaker in? And do we know what this is? Hurry, it's going to come up. I have it delayed, I think. Do we know what this is? So initially we have what looks like a sinus with a first degree, and then it gets longer, and then we have nothing, right? So this is called sinus arrest. Would you put a pacemaker in this patient? So it turns into sinus arrest. Would you put a pacer in this patient? Yeah. I know, it's a trick question, right? I told you I was going to be getting you guys with questions this morning. So, yes, I would, unless there's like an apparent reversible reason. Maybe they had like a massive MI that blocked their sinus node. So, do you know what area of the heart, like where the sinus node is perfused from? I know I'm asking a lot of questions early in the morning, right? So it was complete, and then it turns into sinus arrest at the bottom. Yeah, so it just degrades. So sinus node is perfused by your right coronary artery, right, that comes along the top. I mean, it can be from, because you saw that the branches go right from the sinus node over to the left side too. So left coronary can as well, or the LAD, I should say. But the RCA is the one that primary supplies flow. So if you have a massive MI near there and you block the sinus node or damage it because of the MI, that might be reversible. It may not be, so that could possibly happen, but most likely this patient is going to be getting a pacemaker. What's this? I know it's a little crazy, this slide, right? So you got a lot of fast stuff going on, you got a lot of slow or pauses going on. So this is sick sinus or a Brady-Tachy syndrome. There we go. This could be another indication for a pacemaker, right? Because we want to treat the really rapid heartbeats with certain medications, and then we also don't want them to get too slow. So what basically happens here is we also want to find if there's a reversible cause. This could be thyroid issues. This could also be something going on with the conduction system, secondary to an MI or something post-surgical, right? Especially for the surgical patients, bypasses, valve surgeries, TAVRs. There is a lot of inflammation and irritation around the heart tissue, which can affect the valves and the electrical circuitry, and you can see this a lot. I mean, you probably see quite often atrial fibrillation in the post-op setting. So this is not unusual. One of the things I do want to make point of too is that sometimes we get something called a compensatory pause when a patient is breaking out of atrial fibrillation into normal sinus rhythm, right? Because in atrial fib, you have a lot of irregularity to your heart rhythm with different focuses in the atria, both right or left, bombarding the AV node, making it beat potentially rapidly. And then as the rhythm goes to convert, it would be almost like giving adenosine or cardioverting or shocking a patient. The sinus node now has to wake up and be like, oh yeah, I'm supposed to work now. And then what happens is that the sinus node is not working properly, and then when it does, it may take a pause for it to work and to respond, and that's why you're going to have potential, we call a compensatory pause in the setting of a patient converting. All right, so I'm spending a lot of time on these. Let me keep moving. So types of devices. The reason why I brought defibrillators, even though it's pacing, all defibrillators have pacemakers in them, all of them. Whether it's a single chamber, a dual chamber, or one that's called a biventricular or cardiac resynchronization therapy. Pacemakers, though, right, we have permanent, things that are implanted permanently. We have temporary, right, you have your transvenous, you have your epicardial wires, which we're going to see in the post-ops, and then we also have our pacing pads, or transcutaneous pads that we can put on the patient, which most of the time we do try to avoid unless in a serious situation because it hurts. Have you guys seen somebody who's awake with transcutaneous pacing? They will not be happy with you. Hopefully they don't remember it and you sedate them enough for it. Typically in this kind of a setting, we're usually dropping a TVP pretty quickly, right? We have the staff here that can do it. But in the outside setting, EMS arrives to somebody's house, that's really what they have, is transcutaneous pacing. I wanted to show this picture so you can see where everything goes because there's a lot of different types of pacing. So we have a single chamber at the top, which is right atrial pacing. You do not see that too often. That could be used for somebody who only has like just purely sinus bradycardia or sinus node dysfunction. I rarely see that. We do not do it at all. And this is placed by a device going under the skin and then using a vein like the subclavian vein or the axillary to be able to place the leads into the heart. That would be what we call, I'm going to start using modes, AAI, right? Because you only have a lead in the atrium. Good morning. If you want to get stuff, there's breakfast and everything too. The second one's a single chamber RV pacing. So that is a lead that goes into the right ventricle. You might see those patients. That's a VVI. That would almost be like a transvenous pacer too, right? So there's a TVP that's placed right into the ventricle. Dual chamber, right atrium and right ventricle, biventricular. So we also call this CRT, or cardiac resynchronization therapy. That's the ability for a lead to be in the right lower chamber, and that's the one over here, D, on the right lower chamber, and then also goes through a cardiac vein to the left side to get the heart to contract simultaneously, improve cardiac output, hopefully, and reduce congestive heart failure. Usually we put those in patients who have heart failure with some form of a bundle. HIS bundle pacing basically is a conduction pacing lead. We put it right near the HIS bundle. There's another one called left bundle area pacing. You may see it written in notes, LBBAP or LBAP. That's in order to pace the HIS to improve contractility between the right and left side, or we put it right on the septal wall. Here it would be. And that is supposed to depolarize the left side and then the right. So that's why we call it left bundle area pacing, because it's sitting right on the septal wall, without having to put another lead over onto the left side into through the coronary sinus. The coronary sinus is found in between the right and the left upper chamber. This is a little tiny opening to allow us to pass the wire into the cardiac veins on the left. And then the last one, and I have examples of these, is leadless pacemakers. So that's a new thing. Leadless pacemakers. We have one that typically goes in the ventricles. It acts like a single chamber device. But now we have a new one. Abbott has it, where we put a leadless pacer here, and then one in the atrium, and they speak to each other through Bluetooth. So it's kind of cool. So patients who have no access to put devices in, or patients at risk for like infections long term, dialysis patients, patients that got tons of lines, patients that go home maybe like with infusions and they have no access, we sometimes will put those in patients.
Jen, how long do those last for?
Those devices?
Yeah,
the leadless pacemakers. So the I don't know, am I really supposed to say company names? I don't think so. I don't think I'm supposed to. One of them lasts about 6 to 8 years. The other one, so it's interesting. The other one, if it's a single chamber, they're telling me up to like 15, 20. If you do the dual chamber, a little bit shorter, depending on how much communication that they need. Usually anywhere between 8 and 10.
And if they extend that time, then what happens? Because I'm assuming you can't take it out.
You can take it out, actually.
You can take it out.
Yeah, you can take them out.
I'm assuming there's some sort of like tissue that grows over it.
It does, but there's this, because it's like a screw. I have actually the examples of both of them here. I'll show you at the end. We'll do like a little show and tell and play with everything, and I'll show you. There's this actual the way they place it, which is also nice too, is that we use a femoral vein approach, and what we do is we go up with a catheter into the heart, and there's this like capture piece, and you'll see on there there's like this like little area on the top of the pacemaker. It's like a lasso attaches to it, and you can twist and remove it. So you would think though that it would seal really to the heart tissue. 15 years out, it's gonna be interesting to see if somebody has to have it removed. They said you can also, if you can't remove it, you can drop another wireless device or leadless device into the heart. All right. So temporary pacing, right? Our lovely box here. There's 2 reasons why we use this. Why are we going to use this? In what situations? What are we attaching to this? The cables, right? And what type of patients? Like what do they have? What are the 2 types of pacing that they have that goes to this? Transvenous and epicardial. Yeah. So not transcutaneous. Transcutaneous, right, goes to your defibrillator box. So we're going to talk about later. These are the things I just want to say. There's electrodes, right, that go to this. Electrodes either by epicardial wires or by a TVP. And a TVP can be placed anywhere in the neck area, the groin area. Neck is usually a little bit better because if you want to get them up and sit them in the chair, you have a little bit more stability than anything in the groin area. All right. And the things that we always want to troubleshoot, right? The biggest thing, what mode, sensitivity, and troubleshooting. Is he stuck? Come in. Hi, come get breakfast. How are you? So pacemaker modes, right? So this is where it's like alphabet soup. Everybody's like, what is going on here? What do all these words mean? And guess what? You're going to be professionals by the end of this, and I'm never going to get another question about this ever again. So, and if you want at the end, I can give you my slides. I should have printed it out. I have the nomenclature. I'm going to pull it up. If you guys want the actual nomenclature, I can send it. If you want to print, I can give you copies. So obviously it defines the chambers that are paced and sensed, defines the pacemaker will respond to intrinsic events. Intrinsic means the patient's native rhythm. So some people will use the word intrinsic, some people will use the word native. That's their own heart rhythm, and it responds accordingly to that. And then defines modulation. So the last letter, which is the R, is how it's going to respond. Respiratory it can respond to, activity it can respond to. Right, because if someone has sinus node dysfunction and their heart rate doesn't go up, you don't want them sitting at pace at 60 all the time. You want some variability in their heart rate. So a lot of times we put this R on to be able to respond to that. So this is our famous nomenclature, and my slide didn't change. Okay, so there's really 5. We don't ever see 5. The 5th one is like if they have shocks, if they have anti-tachy pacing, it's really for the EP world. But for basically anyone that's looking at pacemakers or how to set these type of devices, or people who are working with pacemakers, this is the nomenclature we look at. So the very first, let's just use simple DDD. D, right, is dual. So that means it's going to pace both the atrium and the ventricle. If it's AAI, or it starts with an A, what are we pacing? Atrium, yeah. So, and then V obviously is ventricle. So you can have AAI, we can have something called AOO, we can have VVI, VOO, and then we have DD, DDI, DOO. You see alphabet soup, vegetable soup, listening. Chamber 2, or chambers, or number 2, is what we're sensing. So sensing is what it's picking up, what it's seeing, right? So A, atrium, V, ventricle, and then dual. And then response to sensing. So O means none, so it doesn't care what it's sensing. So people who we put like a magnet, and I'll go over that a little bit later, if you put a magnet over the device, it sets it to, we call it asynchronous, which is like a VOO, AOO, or DOO mode. Means it's only going to pace regardless of what the native or intrinsic rhythm is doing. We do that for a couple of reasons. Say someone's in surgery, I'm going to touch base on this again later. Someone's in surgery, we don't want them to have any kind of external interference. Maybe they're going to do something at the bedside. You got to be careful, like say scopes on a patient. If they're going to do any kind of cautery, electric cautery, or any kind of lasering could interfere with the device. You may want to put a magnet on. Ignore that, because that artifact can interfere with the device. So the last thing you want, right? Somebody's pacer dependent, and they go and they're getting some kind of laser procedure or some kind of surgery, and now the laser or cautery affects the device and they inhibit pacing. That's everybody's day, right? You don't want that at all. So that's important to know. Inhibited means if they have a pacemaker discharge is inhibited by a sensed signal. And then triggering means that for pacemaker will discharge after every sensed signal. Rate modulation I mentioned. Breathing, walking, activity can all be regulated by rate. Questions about this? Lots of letters, lots of variabilities, lots of things that can change with all of this. So always remember paced, sensed, and how the device is going to respond to that sensing. Is something going to happen with the device? So let's go about over all our modes, all right? AI mode. And the reason why I'm even going over this in this much detail is because these can be programmed, right? AI, can this be programmed VVI? Yeah.
It's usually VVI.
Usually VVI. Unless you have epicardial wires, you can do. So TVP, can TVP be programmed AI? A TVP. Where's the TVP? I have a picture of it later on the x-ray. TVP is only in the RV. You can only, transvenous pacing, you can only place in the RV. There are some centers that they have placed in the atrium. It is rare. Most of the time you're putting it in the ventricle. So that would only be VVI. But if you have epicardial wires and you have both of them and both sets are working in the atrium and the ventricle, you can do AI, you can do VVI, you can do DDD on this. You could even do DOO. You can overdrive or asynchronous pace. So that's why I want to go over these, because when you're at the bedside, you're going to need to know how to set this, and I'm going to go over like situations in a few. So atrial pacing and sensing, right? If there's native or intrinsic atrial activity, it's sensed, then pacing's inhibited, right? Because A is pacing first, second is sensing, and I is inhibiting. So if there's no native activity sensed, then the atrial pacing is initiated. So that means if there is no atrial or P wave, it will pace based on the rate. So if you set it AI 60 and the rate falls to 50, the device is going to see that and it's going to pace, right? So it's, yeah, so what it does is AI, so it's pacing is the first, sensing is the second, and I is inhibit, which means if there's a sensed beat, if there's a P wave, because this is all about atrial activity now, if there's a P wave, then what happens is that it won't deliver a pacing output. But if there's no P wave, so if it's set at 60, AI 60, if the intrinsic or native rhythm is dropping below 60, the device will kick in to pace. Mm-hmm. And patients don't feel this typically. They should not. The only time that they might feel, obviously, like I said, transcutaneous pacing. It is rare. Patients may feel sometimes pacing, but it's not common at all. And then AI might be used in sinus node dysfunction with an intact AV conduction. The other times we might do, right, in the post-open heart patients, maybe they just have sinus bradycardia. They have their own ventricular response. Do we need to pace both the atrium and the ventricle in that situation? No, we shouldn't have to. The only time I would say maybe pacing both if there's like an extremely prolonged AV delay. So the atrium takes too long to get down to the AV node, which is what interval? P wave to AV, PR interval, yeah. That's your PR interval. If it takes way too long, it could affect filling, it may affect cardiac output. You'll see in this type of setting too, you can easily set this to AAI only, hopefully if there's capture with the epicardial wires. So that's why it's important to know that you don't have to do DDD. If they have their own native rhythm, in any situation, it's always better for them to have their own native rhythm, all right, if you can, unless you think it's going to affect their pumping and filling times. All right, VVI mode. So what's this one now? What's the first V stand for? What is that? So ventricular pacing, and the second sensing, right? And then the I is inhibit, right? So if they have their own native rhythm, it will, so chamber paced right, chamber sense ventricle, response to sensing inhibit, so ventricular sense inhibits the next scheduled ventricular pace. So this is an example, right? So this is VVI only ventricle. So it's timing. So it's pacing here, 1,000 milliseconds or 60 beats per minute. Every second it's going to pace if the patient's own native or intrinsic rhythm is not going to pace. So this, you may see this on somebody who's got an implanted device, because maybe they have a single chamber. You will see this if you're using this with epicardial or with with transvenous system or transvenous pacer, and that's what it would look like. So your setting would be, say it's 60, whatever your rate is, 70, 60, 80, 90, whatever it is that you want, that the physicians or the providers want to put it at. Okay. This is another example. So you see how the V-sense came in here? Why do you think that happened? Because some people are like, oh, the pacemaker didn't work, it didn't capture. There's a beat that comes through. Yeah, their own native rhythm comes through. So it doesn't have to pace, right? So that's the VVI. It inhibits because they have their own rhythm. Now, there are other issues, and I'm going to show you later, that nothing shows up at all. There's nothing at all. And that's a whole nother problem, and we're going to go over that. But that's how both AI, VVI, and DDD work. If the patient has their own rhythm, it's not going to need to pace. You see an output from the patient's own rhythm. If it falls below whatever rate you set it, then it may have to pace. Okay.
Sorry.
Yeah. You need me to go back? Or?
No, you don't
okay.
have to go back. But when you look at the monitor and someone's being ventricularly paced, they have a wide, what looks like QRS compared to their own native. Why is it so wide?
It's because you're causing a bundle, right? So, and it's a very good question, because that gets very tricky.
Sorry.
So if they have, tricky in a couple, so if they have this, it's going to be wide. Okay. Because you have a lead in the right ventricle, right? So remember in the beginning I showed you, I know it's kind of boring, but you have the normal electrical pattern and how the electrical signals go down to the ventricle. So now we're down to the ventricles because you have this lead. When the pacer causes contraction, what is it contracting first? Where's the wire? The right ventricle. So the right ventricle is going to contract first or depolarize first, right? So what does that do? Right, and then the left's like, oh, let me kick in. And then, so you're going to have an offset or a delay. So that's why, then we also have these cardiac resynchronization therapy. So that's why it's wide, because you're actually causing a bundle.
Gotcha.
That's why it's wide. So everybody understand that? Right? Because you're contracting the right ventricle. So what happens is that when the electricity contracts in the right ventricle first, you are causing a bundle. That's why it looks like a bundle branch block, right? So it causes actually a left bundle branch block because you're contracting the right first. Right's coming in first and then left. So the electrical signal is going from right to left. So there's a conduction delay, we call it, which then causes a bundle. That's why it's wide. To make it more confusing, go ahead.
That's the machine here that's causing that?
Yes.
Okay.
Yeah. So that's why in heart failure patients we hate, or don't like, I should say, RV pacing, because you can worsen synchrony. So patients that are going to pace all the time in the right ventricle, we have to now contemplate, is this going to be the best thing, just RV pacing only, or do we have to give them other advanced type of treatment like cardiac resynchronization therapy or this left bundle area pacing? That's the wire that goes over to the left side of the heart, or the one that goes on the septal wall, the left bundle area pacing. Because now, so now this is where it gets confusing. You're like, oh, the patient's pacing, the QRS looks pretty narrow. It doesn't look like a left bundle. Because sometimes if we can get these wires in really good spots, well, not me, but the physicians who implant them, when they get into a really good spot, they get such good contraction and timing between the right and the left. It actually makes that bundle maybe that they had natively or caused by RV pacing to shrink right up, almost to look normal, and it doesn't even look like it's paced. And it's very tricky. Sometimes, I mean, you guys have seen it, right? It's like, it's hard. You look and you're like, how do you know it's pacing? Like, sometimes I don't. Like, I look at it and I'm like, is that pacing? And the other thing, too, that makes it a little tricky is that now when we pace, and this is a little outside of what I wanted to talk about, but I'm going to do it quickly. On the tips of these wires, there's these little poles that can pace between here. So we call it, I don't know if you've heard bipolar and unipolar. I'm just going to do this really quickly. Bipolar is pacing right from the tip of the lead between two poles. That means you're not going to see that big pacer spike that we're so used to seeing. Unipolar, though, is from the generator or can to this. Much larger area pacing, typically you're going to see a much larger spike. So some of the telemetry monitoring now is pretty savvy and can still pick it up. So sometimes we could still see spikes, especially on the newer telemetry model, new tele monitors. All right, that was like a little extensive, but you guys good on that? Yeah. All right. So remember, right, RV pacing can cause a bundle, which is why it causes it to be wide.
So, like, for instance, when someone says, like, oh, they have a pacer, but when you look, you don't see any pacing. Like, you know what I mean?
So if somebody has a pacemaker, and does that mean they have to pace? No,
not
right?
necessarily.
No, it depends on what their own
What
native
their
rhythm
native
is
rhythm.
doing.
Okay,
Yeah.
gotcha.
So you could, even if it's programmed, so people have DDD in their head. So DDD, dual chamber pacing, dual sensing, dual, like, inhibit and trigger, meaning depending on the sensing and what the rhythm is doing. They may not pace. And I've gotten those calls. Oh, the patient said, we heard DDD 60, but the rate is, their own rate is 80. They're not going to pace because it's set 60 maybe to, let's just say 120 is their upper rate. So they may not pace. It's all about timing of their own rhythm with the device settings. Hey, how are you? All right, so we kind of went over this already, but this is basically the DDD mode and what happens. I'm going to let me go to the slide that goes over it. So there are, as I call it, 4 phases of DDD, and this is where it gets tricky. We were just talking about, because people think, oh, it's supposed to pace automatically. So you can AV pace, right, because it's dual chamber, depending on what your rate is. You can atrial pace only in V sense, because maybe the ventricle contracts or comes in at a good timing. Or you can A sense and then V pace, right, because the atrium or sinus node kicks in, but there's too much of a delay from the AV node, from the sinus node, to the AV node, and it'll ventricular pace. Or you may not pace at all. So just because they have DDD pacing doesn't mean that they're automatically going to pace. All right? Confusing, right? Sometimes. Yeah. And sometimes, like, even we look at it and we're like, okay, what is happening here and why is this occurring? And you can have it even every other beat. One beat could be normal, and the next beat they're pacing. And then there's other algorithms, which I don't want to go into too much detail, but that can make this look even worse. Like, patients have premature beats, it may start pacing, and now the rate's at 80, but you told me the rate was at 60. And you're like, why is this pacing at 80? Because these algorithms within these nice little fancy devices that try to overdrive types of rhythms. So it could pace faster too. So just to make it a little more confusing, but just in general, remember this. If they're DDD, you can have a lot of variability to what you're going to see on a telemetry strip or on your EKGs. What's this? So this one you get to cheat a little bit because it makes it a little easier what you're saying. pacing, right? So you see spikes here, which kind of helps a little bit. So right when you have an atrial output from the device, you should see a P wave that comes with it, right? Because you're contracting the atrium. And then the same thing with the ventricle. You have a spike, you should have some kind of output. And then again, this is probably not a BIV because it's a pretty wide QRS complex. And that's what you would see in a likely DDD mode or DDD if you have atrial and ventricular epicardial wires for this. All right, so troubleshooting terms, everybody's favorite thing, sensitivity, capture, and output, right? So when you have this, so you're never, right, going to have to worry about this for the most part on your units, but you're going to have a lot of patients who have these. And we focus a lot on this. So if you see stuff that's funky, who are you calling? You're calling us or the companies or what have you. But you have control over this, complete control. So you can set all this, and I'll go over at the very end, whoever wants it, I can do a hands-on how to set different things on this and what you're looking for. I'm also gonna talk about it, but sometimes seeing it is a little bit better. So sensitivity, right, is what it senses. What is it picking up? What's the signal? Does it pick up the P wave? Does it pick up the QRS or the ventricular, atrial or ventricular response? So pacemaker senses electrical activity, and there's things called oversensing and undersensing. So oversensing would be that it thinks it sees something that's not there. So for example, I mentioned earlier, electrocordial lasers, that could be picked up, right? The device thinks that it sees something and it doesn't give an output. Could be a really bad situation because maybe the patient's got complete heart block and it doesn't deliver a capture. Undersensing means that it doesn't see it and it's delivering output. And where would that be bad? What happens if you undersense, it doesn't see the patient's own signal, and then it paces? I think I talk about it later, actually. It can cause premature beats, but what happens if you get an RNT phenomenon? If ventricular paces, smack on the QRS of the T wave during what we call something called refractory, and then it causes them to go into RNT. Really bad situation. Capture and output. Capture means what level do we need for the MA, specifically the MA on this, in order for the device to capture. That's what that means. Output is also MA. We use output a lot on this, but you could use that term for here. Capture is probably the more common word, but I wanted to use both in case you ever hear people say what's the output or capture on the device. So we have MA or voltage that's needed in order for the pacer to capture, like I mentioned. Testing involves adjusting your MA or your voltage. Voltage is on this, MA is on this. And then we talked about failure to capture and what to do. So we're going to go over that. All right, but these are the things that you need to know when you're going to troubleshoot a patient, that you're looking at something on the monitor, you're like, I don't know what's happening here, or I need them to pace. What can I do with this machine? Okay. So remember this, because we're gonna test you on this later. So this is intermittent loss of capture, right? So we see P waves, right? So P waves is that first little blip, right? And then, is this sensing or pacing? And does it capture or not capture? Captures, right? But what about that middle one? Not so good, right? So we see a spike. Normally we don't see these huge spikes anymore, but you see this big spike. There's a loss of capture. The reason why we call this loss of capture is because you can see the spike is if you measured this with calipers or what have you, you can see the output trying to be output from the pacer is at the same interval, but it doesn't capture. So that could be, a huge problem if it keeps happening. And it's something that you can adjust both in this device and this device. You would be setting the MA on this. Okay. All right. Do you know what might cause this? This is important for you to know because you could see this in your units.
And with the TVPs, sometimes they move.
Exactly. So dislodgement, right? So for TVPs, or what about with the epicardial wires? They just may not be working, right? They may not be working. So with these devices though, right, they're coded There could be insulation breaks. There could be issues with this. There also could be what happens if the patient had like a massive MI, right? There could be damage to tissue, and sometimes certain medications can also cause, we call them pacing threshold increases, like amiodarone. The way it affects the tissue of the heart, it can sometimes increase pacing thresholds. So sometimes we need to give them a better output. And that's typically from more so long-term with the implantable devices. So lead fractures, right? Big thing, lead dislodgement. So huge thing to check where that TVP is. And then also making sure your settings are okay on your external pacing.
Acidosis doesn't cause any interruptions.
You can. So that would be a whole nother like physiology, and I didn't want to go there, but I'll just briefly touch on it. Your heart tissue has a lot of electrolytes, right, that go through it. So you have sodium channels, you've got chloride, you've got calcium channels, you've got potassium channels. So if you're acidotic, right, what happens? All those channels could be affected. If you are grossly hyperkalemic and acidotic, you can affect those signals. You can get profound bradycardia with that. You can have AV conduction issues. If you have hypokalemia or sodium that's affecting, you may affect contractility and also the electrical signals that go through the heart, and you might wind up having things like VT or VF. That's just some of them, but it absolutely can, depending on the significance of it. All right, but good question. That's like a whole nother class to talk about. All right, so let's go over these. Undersensing, failure to sense. I kind of touched base on this a little bit. So a pacer fails to detect the patient's own rhythm. It paces unnecessary, so this is undersensing. It doesn't see the patient's rhythm. It gives an output from the device, whether it's the temporary or permanent device. Patients may feel something. They may feel like extra beats, and then you may see that and I have an example at the end. It just happened yesterday with a patient that it will deliver a spike somewhere. And you might see it in the middle of the P wave, you might see it in the middle of the QRS, you might see it in the T wave, depending on when it delivers. And the treatment for this would be increasing the sensitivity. So have we all talked about the fence with sensitivity? High fence, low fence, it's written everywhere. I don't even know who originally came up with it, so I'm not giving them any credit, I forget. But there's a high fence and a low fence. So if your fence is really high, you can't see over it. That means the higher the number, right, the less sensitive it's going to be. People think the opposite. Oh, it's a high number, I'm going to pick up more. No. The fence is higher, you can't see. You bring that fence down or the number lower. So I'm going to use a number of, say, 0.05 up to, like, let's say 2. 2 is going to be less sensitive, right, because it's higher number. You bring the number down to 0.5 or 0.05, whatever the case is, you're going to see a lot more. So that's where your sensitivity. So if you undersense, you want to increase the sensitivity. So you want to make the number lower. It sounds opposite though. You say, oh, I want to increase it. So you want to increase the number. You don't want to increase the number. You want to bring the number lower. You want to be able to see over that fence and bring it down as low as you can without now oversensing, because that's where that gets tricky. So oversensing, pacer interprets non-cardiac electrical signals. It could detect maybe something extraneous that produces, muscle stimulation, and then things that the patient is having pacing, and they're not. Has their own rhythm, and it will inhibit pacing from occurring because it thinks it sees something naturally. So inhibits itself from pacing as it would, and then that's going to be also adjusting the sensitivity, where you want to make it a little bit less sensitive or bring the number up. You want to see a little bit less over that fence. Clear as mud, right? Yeah. Everybody gets very confused with this. Oversensing and undersensing. So, okay. So this is something you might see. I'll show you a strip at the end. Pauses are longer than normal. And what happens with oversensing, right? If they don't pace, it can contribute to decreased cardiac output. They can get lightheaded or dizzy. They might pass out if it's really inhibiting a lot and they're completely dependent. And like I said, we have to reduce sensitivity. All right, so I just went over this. So did I do that twice? I might have done that twice. Sorry. All right, let's go. Oh, capturing. Let's talk about capturing now. So if you're not capturing, it has nothing to do with your sensing. It's sensing properly, but you have no output. Remember I showed you the other one, loss of capture? There was no output. There was a spike, but there was no output. What do you have to do? Let's talk about this. What do you think you have to do on this? If you have loss of capture.
Check your wires first.
Yeah. Make sure it's connected. That could be part of the problem. I've seen that before. Comes loose, especially epicardial wires. But you know, you're hooking into all these like little. You have the wires, you have the TVP. You're hooking it into like the two little. Well, the one port. Then you have it going into this. Is it snug in here? If everything looks like it's connected, the next thing is MA. What happens?
So the battery's good.
Is that? Oh yeah. Is it blinking like? And the lights on this and the battery like, it's not really that visible. I feel like sometimes when you look at it, you're like, oh yeah, the battery's a little bit low. It's like this little thing. Double check the battery. It's a good point. And then you want to increase your MA, right? That means how much output or capture you need. So you should test that, right? When you come in, see your patients and stuff like that, and see at some point. And a lot of people like hold their breath and don't pass out on the patient, but they hold their breath because they're like, oh my God, the patient's gonna go. It's a complete heart block, and I don't want them passing out on me and their blood pressures to drop because they're already critically sick, right? But you can do a nice thing just to see what their underlying thing is, which is nice now because we used to in the old ones never have this little like pause button here on the bottom where you can hold it and then you can see what their underlying rhythm is for a very brief period of time without really hurting somebody. Back in the day, we used to have to turn the rate all the way down. Sometimes we were even daring and unplug the top and be like, okay, they need the pacing, and plug it right back in. So now we have this nice little fancy button on the bottom that we can press and pause and see what their underlying is. So that being said, when you have capture, if you lose capture and you need to increase your output, if your output is set, let's say at 5, go up to 6, you can go up to 7, go to 8, or go backwards. Start at like, the leads are different. One it goes up to 20, one goes up to 25 MA. Start a little higher, maybe start at 15. Oh, it captures 14, 13, 12, keep going down. Wherever they lose capture, obviously you want to go a little bit above that. So if they lose capture at 5, you don't want to leave it at 6. I would say give them a little bit of leeway. Some people, rule of thumb, say 10%. In these devices, we give a lot more. The permanent, we do double whatever it is, or 1.5 to 2 times whatever our capture is. With this, you want to do at least 10% or a couple of MA above. So if it's 5, I would say you want to do probably at least 8, 9, somewhere around there, just to give you a safety margin. Like we talked about, make sure if they're doing transcutaneous, make sure they're on properly, they're sticking to the patient, you have it plugged in all the way, and then setting up the pacing. All right, questions about that?
Should you be concerned, Jen, if you're continuously having to go up on your MAs in order to achieve capture that your wires may become faulty or?
Yeah, it can be. Yeah.
Okay.
Yeah, so you gotta remember, right, especially epicard, well, all the wires, right? So the likelihood really of like fractures in these wires and stuff are pretty small, even in like the permanent devices. The risk of lead fractures are like 0.1%, if that. It's pretty small. Same, and these are a little bit more, there could be, because they're so thin, they don't have the protection or coating like these wires have on them. And you see these are very flexible because the heart is a very strong muscle and it's got to contract against this, so the coating on this is a little bit more, I'm going to use the word viable, or will last longer than an epicardial or a wire or TVP. But it is a good point. You have to make sure that that's not the case. Yeah. So usually what I'll do too is that, remember, you say, oh, you look at the TVP, and maybe it is in the ventricle, but maybe it's on the same spot of the ventricle that it was. So you gotta remember, maybe the patient had an MI, and now this wire is trying to deliver some kind of pacing output in an area that's been infarcted, and there's scar, so your output could go up. And that's the same situation we could even have with implantables. So it's some things to look at. So x-rays are really important to look at about placement. Not only that, if the lead does move too, and it's just kind of like flopping around in the ventricle, or God forbid, if you have somebody that has a TVP in, and all of a sudden they're starting to have VT, obviously, don't walk away and be like, oh, let me go check the x-ray and see what's happening, leave the patient in VT. Treat the VT, obviously, but look at the x-ray and see the position.
I know we've had before where like one of the wires goes and we have one other one, so
Yeah.
they put in grounding wires.
Yeah.
How do those work exactly?
So
Like a grounded wire.
The ground, you mean on the epicardial wires? Yeah, because you have two wires.
Right.
So you can, that's why, so you're going to be pacing from two areas.
Okay.
It uses both to pick up the signals on there. So that's how you mean that they have like you're talking about like they have two A's and two V's?
Well, they have two A's and two V's, and then say like one A goes, and we've had like doctors put in like a grounded epicardial wire.
Right. So you can still use that the same way.
Okay.
It'll still pace. You can use that wire. Well, the grounding wire is usually on the ventricle.
I'm assuming, Sam, what you're referring to is when they suture those wires onto the surface of the heart.
Yeah.
They don't always do that. It basically sits on the surface of the heart. They
Right.
actually suture it. So you notice when we pull versus clip, I think those grounded wires that you're referring to is what they suture on.
Dr. Zhang has like just like put in grounded wires.
Yeah.
Yeah. I've never
There-
seen them do it.
No, most of the time you don't see that too
Yeah.
often. Sometimes they'll use it, it's like a backup wire in case the
Yeah.
other ones go. That's all that is.
Okay.
And then what Marlene's talking about is, right, so you have epicardial wires, a lot of times we can't just pull them because sometimes they're in too long and then, right, cardiac tissue adheres to them, so you can't just pull them out. TVP, so you can pull out, right, but a lot of times they don't work as long either and you don't want to pull any kind of cardiac tissue. Sometimes you might have seen lately too, you can do temp to permanent pacers where you put wires in that are permanent pacemaker wires because the patient maybe have complete heart block, but they have an infection and they need to be treated long term, but you don't want to put something permanent where everything get infected, and then they have the can sitting outside their chest or the generator sitting outside their chest. You cannot just pull those because you're going to do a biopsy on the patient. Those wires, there's like a one on here. The wires, I don't think I could do it because I don't think I have the right equipment. If you turn this piece here, the sensor comes out the tip. Actually, you can see it a little bit. I was able to turn it. That adheres into the heart tissue, and if you don't twist it back to retract and you go to pull it, it's going to pull heart tissue. And you're going to look at the end and you're going to be like, oh, nice little biopsy. So you don't want to do that. Oh, yeah. No, you got to stand like I have to stand. I'm sorry. Look at me. I'm not even paying attention. Sorry, Zach. Sorry. Here. Yeah.
This may be sound like a really, really silly question. So we had a patient the other day who had a CABG AVR. The patient came out. I wasn't there, but apparently, Sam, I think you were intermittently in the room that day. Dimitri basically held pacing. The patient was asystole. We were pacing. I believe it was DDD or DDO when we initially came out, right? Somehow or another, while we were in the room, we started having some asynchrony in terms of the pacer spikes. And what was happening is we would have pacer spikes that were landing directly on the QTCs.
It was probably.
It was also the patient's rhythm was coming in, right? So the patient's own intrinsic rhythm was coming in. So we had the pacer spikes landing directly on the QRS. QRS was definitely narrow, right? So we stopped it again. And then the patient had like some intermittent junctional with sinus brady. So then we decided to go on VVI, but then the patient went back into an asystole again, and it was just all of this back and forth, and the patient was fresh post-op. So I understand there's going to be conduction abnormalities. In terms of your selection of the most appropriate setting, I was just like, Dimitri, I don't even know what you're doing right now, because but what are we doing?
I ask him that often now. I love Dimitri. Don't tell him I said that. I'm joking. That's when he calls me and he doesn't know what he's doing. He's like, Jenny, I need your help. So what that sounds like is sometimes after surgery they put them in DOO mode, right? So DOO is asynchronous, which basically means, sorry, I just need a sip of water. It doesn't care what the intrinsic rhythm's doing. It's going to pace, which can get dangerous, right? So people who do DOO will usually say, we do it like in an MRI setting. If a patient's pacer dependent or uses pacing a lot on the permanent devices, DOO or VOO, whatever the case is, it doesn't care what the patient's rhythm. It's going to be set. If I say DOO 70, it's going to keep giving pacing outputs at 70. It does not care that there was a beat there. It doesn't even look at it. So that's what that sounds like. Could have been that maybe they came up in that mode. And then what winds up happening, which is the correct mode to select? don't remember if I go over all that too, but the correct mode to select depends on what the patient's doing. If you're having intermittent asystole, I would say just leave in DDD mode because you don't know. And you can play around with the settings on this. You can play around with rate. You can play around with PR interval or AV delay, we call it. You can play around with the sensitivity and the MA on this. So you can say I want DDD, but maybe it'll only atrial pace because of the rate because you extended the delay on this long enough. We can do that obviously with these too. Like we can program a lot with these. You can do that. If it's a patient that's just bradycardic and you need increased cardiac output, you can just do AAI or they're junctional and you want to try to get some kind of capture. Sometimes with the junctional, there's so much irritation in the atrium that they may not capture, so you're going to have to do DDD or a VVI just to give them that output. But if they're bradycardic, I would say AAI. If they have a ventricular response, why do we have to pace? Always allow their intrinsic rhythm if they have it. But if you have someone like this who's having intermittent asystole or pauses or heart block, why are you going to play around with just AAI? Because if you just did AAI, right, then you may not capture in the ventricle. If you do VVI, now what's happening? You're only looking at what the ventricle's doing. So you're not even paying attention to what the atrium's doing. And if that means you're going to have AV desynchrony, right, which can also contribute to cardiac output. It could also contribute to blood pressure fluctuations, filling times, diastole, all that type of stuff. So you want to definitely make sure, try to get the atrium contracting with the ventricle. The only time you want to do the ventricle is if you're stuck, atrial wires are not working, all you have is a TVP, right, because you're in that type of a situation. The patient comes in with a complete heart block and their rate's 20 or 30 and their blood pressure's, 70, systolic. You want a TVP and you're not going to be playing. In your situation, you have epicardial wires. If the atrial wires are not working, and you tried everything, you put the MA up as high, then you have no choice than to VVI pace. Yeah. But the optimum in that, I would say, would be DDD in that situation because you have intermittent asystole or pauses. Yeah. So I talked about this a little bit earlier about electrocautery or magnetic interference. The reason why I bring this up is because you're going to have patients that go for procedures. You're going to have patients that have to go for MRIs, and you want to be aware of potential interaction with the devices. And I kind of talked about this earlier. So electrocautery or any kind of lasering, it can inhibit or trigger output, right? So it may see or not see something. It can revert to a synchronous mode because it thinks it sees something and revert the device. It can cause inappropriate programming. It can cause AFib or unfortunately VFib or VT. And then also, if it heats up the wire, and this is more so even like with MRIs, it can actually damage tissue. That's why we always want to make sure, I think I have a slide on MRIs, we want to make sure that the wires are MRI conditional when they go for that. Defibrillation may cause permanent damage to the pulse generator, again, burn tissue, or interfere with the device. And radiation therapy. Defibrillation meaning like external defibrillation. Don't ever put the pads directly on top here. Your best bet to put the transcutaneous pads is here, right on the sternal border, and then some people you can do here. If it's a really big patient, I like putting it, if you can, turn them and put it on the back. And do you know why I'm saying that? Right, so if you have a much larger patient with a very big chest circumference, if you go here, right, the heart is huge. It's probably kissing this side. You may, because you're going this vector here across, you may convert them, but you might be better off going right through the chest and shocking them this way. So depending on the patient, obviously if they're in it and you just like get them on time to turn them, do that here and make sure the pads are on correctly. Radiation therapy, so don't ever put it on top. It could possibly damage the device. Radiation therapy may also cause issues with the circuitry or reprogram the device. And then I have MRIs. So I have MRIs contraindicated with asterisks because it's not always contraindicated. Some people can go for it, an MRI, but we want to make sure that the patient is cleared for it. So usually what you want to do is patient may know, but 99.9999% of the time they do not know. They don't even carry their ID cards with them, even though we tell them to. If they have the ID card, it usually will have the EP physician or the following physician on it. You can give them a call. And if uncertain, obviously we can call the company or our group and we can help you out if the device is MRI conditional. When the patient is MRI conditional, we do have to set it to a safety mode, which is like that depending on their pacing. If they don't pace really ever, we don't have to put them in an AOO, VOO, or DOO. Why am I saying it has to be asynchronous? You just want to pace because the MRI could interfere. Again, it may think that it has their own rhythm based on the magnetic field, and then it would inhibit pacing. So you want to asynchronously pace and just pace. So that means if the patient's intrinsic rhythm is 70, would I want to asynchronous pace at 70? Would I want to do DOO 70? Exactly. We usually say about 10 beats above, because now it may compete, and then you might get that RNT phenomenon. So you always want to be a little bit faster than what the intrinsic rhythm is. All right. Questions about that? No. Okay. All right. Deactivating. Right. So you may see this as well with the devices. So deactivating. So if it's I want to bring up defibrillators here, right? So people get shocks from defibrillators. Maybe it's inappropriate shocks, and the inappropriate shock can come from, or unnecessary shock can come from maybe a lead fracture. And this is an implanted. If you put a magnet over it, magnets over defibrillators inhibits therapy. Shock therapy only, not pacing. All right. So if you have someone that's having, like, you look at the monitor, like, they're not in VTVF, why is this thing firing? There's a possibility that they have a fractured lead or something's going on with the wire. The other way we could do it is come in with our programmers, right, and we can deactivate. If you have a patient going for the surgery, so sometimes you may see this, like you have a patient in critical care and they're going for whatever, their VADS, their transplant, impelled, whatever they're going for, and they have a device implanted. You can also deactivate through the device or put a magnet on them. The other thing you can do is when you go in, you can put them into asynchronous mode. When you put a magnet on, not each company is the same. They all respond differently. When you put a magnet, it could do asynchronous. Like one company is 85. So when you put the magnet on, it'll start pacing at 85 DOO. If it's a dual chamber. If it's a single, VOO. If it's in the ventricle. All right. But usually you would want to call the manufacturer, call us, or whatever the case is, so we could determine what the response is going to be. But in an emergent situation, unnecessary shocks, magnet on the device will inhibit.
I see it depends on what we have, like the Medtronic magnet. Can you use the same magnet for?
You can use a magnet across, yep, on all of them. It has the same effect.
It only inhibits the ICD, it doesn't inhibit the pacer.
No, so in a defibrillator, it affects only shocks, so it'll inhibit shocks. If it's a pacing, it'll still pace, but it becomes asynchronous. So you put the pacer on, you put that on there, and a lot of times we'll say put a magnet on the pacer, sometimes in the OR if they're having something with laser or cautery, that could interfere with the device. Because what did I say happens with cautery or lasers? What can happen? If I didn't have that magnet, what happened? No, you don't have, no, for cautery, like if you do cautery, like if you're doing like a scope or whatever type of surgical procedures, an LVAD, let's say, and they use cautery while they're doing it, the cautery can be picked up as natural electrical signals, or the device thinks it's the patient's native or intrinsic signals, and may inhibit pacing when they want to. That's why you want to do asynchronous or that OO mode, VOO, AOO, DOO mode. It doesn't care what your intrinsic is, it just paces through to overdrive, and it doesn't care what it's seeing. All right?
And after once we use the magnet to take off, does it reset?
It reverts back. Yep. So if you have defibrillator, if you have a magnet on and then you remove it, it'll revert back and go back to shock therapy if it needs to, or anti-tachypacing, however the settings are. If it's a pacemaker, the pacemaker never gets turned off. It's just that asynchronous mode, and then it goes back to whatever the original settings were on the device. All right. What happened?
It's a scary thing.
Pacemakers can be scary. Yeah, they can be. All right. Oh yeah.
I have lots of questions.
Go ahead.
We had an LVAD whose pacer was subcutaneous, so it
Yeah,
couldn't
I have.
be turned back on.
I'll talk to you about it. Yeah, we'll go there. I'm going to show some pictures. So, this is just fun. X-rays. You may not look at X-rays, but this here, I want to show you the difference. I'm sorry, the quality was not fantastic. I was trying to copy and paste. This is a defibrillator, and the way I know it, you see this lead here? See how this is really thick here? That's a coil. That's a defibrillator coil. That's how you know it's a defibrillator. See this up here? This is in the atrium. You see how much thinner it is? Pacing lead. Much thinner, doesn't have a coil on it to shock. Now, if you notice there's a coil up here too, some have dual coils. So sometimes you'll see two coils that goes through the SVC. And then this little thing here, this little right here, that's that cardiac resynchronization wire, or your cardiac vein on the left side to help contractility. So this is what we call as a CRT, or a BiV device. All right. This one is your sub-Q. So this is here. So this is a perfect time to answer. We have two different types of subcutaneous devices. We have one that goes here, sits on the left lateral wall. The wire goes underneath the subcutaneous tissue and then above the sternal border. We have a new one now called Omni EV ICD. It is placed exactly the same, except for now the wire is tunneled under the sternal border. It's closer to the heart. It can actually deliver anti-tachy pacing. So this can only, it's a shock box. So LVAD, let's go to your question. So LVAD is what? Right here, right in the ventricle. So you have this motor and generator going right here to get the pump. This is right here. So it's not that the device interferes with the LVAD. The LVAD can interfere with the device, and it could pick up abnormal signals. It's not electrocautery, right? But it's external interference with the device and could potentially give unnecessary shocks. Yeah. So anyone who's got a sub-Q ICD and gets an LVAD, we gotta turn off the sub-Q.
What's
All
the
right.
benefit between having like a regular permanent pacemaker and a subcutaneous pacemaker?
So, good question. So pacers, we only have transvenous, or I'm going to show you the wireless ones, or leadless. Defibrillators can be subcutaneous. So the difference between the two, or where you would want to, is that one, access. Does somebody have access to be able to put transvenous leads in? We used to implant them many moons ago in the 80s when they first came out, in the belly, and then they would run it up and then put the wires in. We used to even, I have a patient that we still have now, back in the 80s, they had, surgical team had to come on board, and we used to put patches right on the heart. So they used to have these small, like, gel patches that set on the heart. I shouldn't say gel, but they look like a gel. This would be good, and someone has no access that does not require pacing. So sometimes, let's use a young kid comes in with brugada, which is an abnormal electrical channelopathy, or maybe hypertrophic cardiomyopathy. This is the kid that plays, I don't know, soccer or basketball, and they drop dead on the field, right? And they basically just need a shock box to protect them. God forbid this happens again. This is a good one because it keeps their chest kind of, clean, and down the line, if they do need something or require pacing as an older adult, we still have this here. So they just have this can right here. That's another reason. But the biggest thing is usually risk of infection, no access because of maybe like tunneled catheters, dialysis catheters, PICC lines, Hickmans, occlusions, maybe their vascular path, and they have absolutely no access at all in the right or left side. Then we could put this in. All right. Good question, though, for both. Any questions about this? Okay. I don't remember what I have next. Let's see. This is a pacer. And why do I know that this is a pacer? Yeah, really thin wires, right? Much smaller can, right? So I didn't bring a defibrillator with me. I probably should have. The can's a lot smaller because it doesn't need to defibrillate. So you don't need as much energy from the device. So that's how you know. And this is a dual chamber because there's a right atrial lead and then the RV lead down here.
So if you can see the pacemaker coming out of their chest, or if you can see a device coming out of their chest, it's usually
I have a picture of that because that's a complication. So we're going to go over complications too because you guys need to know about complications. I did that instead of all the other I'm going to go over the other complications, but because that one is the most eye-popping when you see it.
Can you remind me again when we had that pacer in which one of the leads was fractured? The positioning. There was a way, and I can't remember the positioning of the leads on that patient where we had to do a lead extraction and revision.
Yeah.
Where exactly did that fractured lead? Where was the orientation of that lead?
So I don't remember. I don't remember which lead it was.
I want to say that it was the first smaller
the atrial lead. Yeah, it might have been. So sometimes, so the nice thing with the technology and with X-rays now or radiology is that we can zoom in, right, make things bigger. Sometimes you can actually, see a fracture.
Yeah.
You can see hairline. Sometimes you can see like if it almost looks frayed too. I should have brought a picture of that. It's kind of cool. Where the wire, like you see the wire is like part of it is like hanging out of this intact piece, but you can actually see the fracture on it on the X-ray if you look really closely along the entire thing. Because it could, and the other thing it could too is that you see up here, these wires go into we call this a header, so it goes in here, right? There's a lot of pressure right here at the header, even though this is solidified or like sitting right here in the pocket. There can be issues with the pin, how it's going in. That can also cause issues. It could be loose or it can break, especially right here because that's metal. Sometimes you can have that too, a problem with the pin, which is a lot harder to see here, on here. Sometimes we could see that the pin goes, you see these things here? The pin goes all the way through. If it doesn't go all the way through to this second one here, that could also lead to issues with sensing and capture and all that too. So a lot of times you'll see that sometimes post-op, that maybe the blood got into the header and it didn't go all the way through and you don't see it through those two pieces. That can be another problem. All right. So unfortunately on this, you can't see, we call them lead impedance. Within the device there's impedances. And then when the impedance is off, it can tell us if there is a fracture or something else going on with the wire. This you can't tell on that. Because it's pretty rare these devices get removed pretty quickly, right? The epicardial wires or the TVPs. So you're not going to typically see a fracture. If anything, it's just not going to be working anymore over time. All right, so this, this is a little hard, and that's why there's an arrow there. But you see there's a line coming all the way down from the neck here to here. That was yeah, it's a really horrible picture, sorry. I don't know if it's going to make that picture any better. It's a horrible picture. It's like over penetrated. So this is the lead of the TVP. So if you have a TVP in and all of a sudden you see it back up here, no good. Turn it off and have it repositioned. You're going to pace potentially up by the tricuspid annulus. You're going to potentially cause VT because it's probably not stable and it's just bouncing around in there. So if you have VT with the patient's got a TVP, obviously don't leave them. Treat the VT first and the patient, but make sure it's not secondary to the placement of the TVP and it's not just bouncing around. All right. So that's radiology. Oh, yay. So shock factor. Implant complications. So the reason, this is the only thing, this is not all I'm talking about, but we have other complications that you need to be aware of. So this is an unfortunate thing, right? Not good. Does this device have to come out? Yeah. Once you have break in the skin, endocarditis risk is like through the roof. Those are really ugly, hot, red, swollen, infected pockets with basically usually some type of infection underneath the skin. Could be variable, so a lot of times when we do remove it, we send it off. What are other complications? It's important to know this too. So you get a patient, they go for surgery, they want to need a pacemaker, they need a defibrillator. What other complications do you need to be aware of in the critical care unit? Any unit. They come in even to the ER, they're in telemetry. So you have infection is definitely one, but immediate post-op. Yeah, bleeding, hematoma, they have to be on anticoagulation. Maybe they have mechanical valves, maybe they have atrial fibrillation, so you got to watch that. Pain, right, is a big thing after swelling. You can use ice packs. You can use compresses or pressure dressings over it. The other thing that can happen, a lead can move, right? So dislodgement, same thing. You have oversensing, undersensing, inappropriate capture, capturing inappropriate, or not capturing the way it's supposed to be. You had a question?
I have a question, just in terms of activity restrictions in the immediate post-op setting. I get that there's, limited range of motion of this arm. What is the time frame and what activities should they refrain from?
So no stretching over the shoulder.
Okay.
Stretching, pulling, whatever side it's on.
For
So the
how long?
leadless, really no restrictions because it's the groin. we just don't want them climbing up and down stairs or sitting in a tub if they have a groin access for at least, I'm going to say 72 hours or so. And they're like scrubbing or rubbing. Obviously, they have to watch for bleeding, hematoma. Same risk, any kind of venous access, right? You can also cause pseudo aneurysm, bleeding, hematoma, the whole gamut. So that's the groin area. For the transvenous system, no big stretching over your shoulder, no big stretching back. With that arm, you can move the other arm. That's why we try to say what's your dominant arm. We try to avoid that, right? Usually the first 2 weeks are pertinent. We try to avoid driving. We try to avoid any lifting over 10, no more than 15 pounds of them. I try to limit 10 pounds. We also tell the patients, right, leave the dressing on. We'll take it off at the office visit unless there's any kind of bleeding, fever, chills, those type of things. Patients can start increasing their activity after 2 weeks. Leads typically take to heal. So the big motion is allowing this to like heal. Because if you keep doing this and this, right, this pocket is just going to keep shifting underneath, and this is going to, now this is small, but defibrillators are much bigger. It's going to shift, and now the patient's going to have like, for women, maybe down there like boob and over here, and it's like shifting all over the place. So you don't want that, because then it's moving as every time they move. The wires, chances of dislodgement are pretty small, but wires can take anywhere from 4 to 8 weeks to heal. But we usually allow patients up to that point to keep like increasing their activity level. The first 2 to 4 weeks are key, with like really big stretching and pulling. We used to limit driving, no driving, up to 8 weeks. Now we've gone back down to about 2, and it depends on how the patient is once they come in. Driving's not the problem. We don't want impact, God forbid there's an accident. The only time you cannot drive is if you had VT, cardiac arrest, shocks from the device. No driving 6 months.
We, as providers, when we put in our cardiac rehab orders, and I'm just going to say this, I never, and I'm thinking about it now as we're speaking about this, never put in activity restrictions after the pacemaker. Is that something that we should start? Like, I know they have restrictions, obviously, but say the cardiac therapist didn't get to look and see that the patient had a recent pacemaker.
Yeah.
Who puts in those order sets?
So the problem is that if we're discharging, we can put that in on that discharge. But if we're not discharging, then it probably should be in that, like, that adult discharge. There's a spot for restrictions.
Okay.
Like, you can even make your own, what's the word I'm looking for, smart set.
Yeah.
With like whatever terms you want to use. I have one, I could even share it with you.
Yeah.
I think we all have, right? We have like the restrictions that you can pull that blurb in, and then it'll be on their discharge instruction.
Because I think even when patients are still here, if they're here for a long time,
Yeah.
I cannot remember ever putting in those restrictions
Yeah.
at all. But cardiac rehab's really good.
They are
Very
really good.
mindful,
Yeah.
But I could see it becoming an issue, especially with
Right.
resources.
Hi. She wants to learn about pacing too.
So, quick question.
Yeah.
The determination of placement on which side this on is based on dominance.
So we start with arm dominance. That's the first thing. Then the next thing that we look at is catheters, right? So if they've got a Hickman in, they've got a dialysis catheter in, fistulas, right? We're trying to avoid causing impedance of flow to any of those areas. So dominance, access to either side of the chest with any kind of catheters, fistulas for dialysis in either arm. And then, unfortunately, sometimes it comes down to is that we're like, oh, they're left dominant, so we're going to put it on the right side or vice versa. And then we go in there and it's occluded and we can't get the wires in. Then we have no choice but to go to the other side. Yeah. So that would be the other reasons why we would do that. Or the other thing too, breast cancer. So mastectomies or ports that they might need, we try to avoid that side as well. All right. So this is an infection, but those are complications. Oh, one other complication that you should know for post-op, tamponade, right? So patient comes up from surgery, blood pressures are horrible, they're dropping, they're becoming a little tachycardic. Maybe it's just a single chamber defibrillator, like a shock box. They start becoming bradycardic. They feel they're clammy. They're starting to almost look like a little shocky pitcher. You want to call somebody right away and get an echocardiogram to make sure they don't have a pericardial effusion or tamponade. And then what's the treatment initially right away for tamponade? Paracrocentesis, but the other thing, it doesn't make a difference if they have heart failure or not, IV fluids, right? Increase volume, right? IV fluids, first thing you can give them. Get the blood pressure up, try to increase contractility a little bit, keep that volume because they're losing that volume because it's going all around the pericardial sac. And then get echo right away, and then CT surgery, or whoever can do a paracrocentesis. Sometimes, depending how bad it is, sometimes they need a window. Hopefully it doesn't get to that point, but sometimes they need a window. All right. It's pretty rare. It's less than usually like 1% risk for that, but it is also a complication, especially in the pacemaker patients. Even though the wires are really thin, I've been noticing that the patients who have infiltrative diseases like sarcoid and amyloid, their tissue is really, really weak and it's a very professional term, mushy almost, and spongy almost, and the wires unfortunately can perf right through that tissue. So those are the ones you gotta be careful with. All right, so that was my shock value picture. So you see that, bad issue. All right, so here we go. Here's the testing. So which pacemaker modes could be operating in this strip? So we have normal function. Nothing's moved, leads are in place, everything's fantastic. What's this rhythm to begin with? It's actually, it does look sinus brady, doesn't it? 350, 175, it's in the 60s. So I'll give you that. So it's in the 60s. So it's sinus rhythm, right? So we have a couple of modes here. DDD mode, VVI mode, AI mode, and DOO mode. What modes can this be? Sinus rhythm, we don't see any pacing, right? So can it, all right, let's start this. Can it be DDD? Dual chamber pacing, dual chamber sensing, inhibiting? Yes. Okay, we got yeses. Any no's? Got all yeses. VVI, could it be VVI? I see some yeses, some no's maybe. Okay, so we've got mix. Can it be AI? All right. Can it be DOO? Okay, so here's your answers. Definitely DDD, right? Because maybe their intrinsic rate's above what the set rate is. Maybe their set rate is 60, this is 65-ish or so, right? So that's one thing. And then the PR interval, even though, yes, it looks like a first-degree block, maybe we gave them a little bit more leeway on that, right? This can also be VVI, right? Because the ventricle is faster than the setting of it, right? So maybe you have VVI 40. This is way above 40, it's not going to pace. AI, yes, because the atrial rate might be faster than how you have it set. Maybe it's AI 50 or AI 60, this rate's 65. It is absolutely not DOO, right? Because it's asynchronous, it doesn't care that there's an intrinsic rhythm. It would just pace throughout. So that's the one that's known. Where are you? Oh, implantable pacer generator. Yeah. Okay. What can this be? So you have, again, normal pacing function. So we have an A-sense, picks up the atrium, but then it ventricular paces. We can see a big Y complex. I don't see an atrial sense here, but I do see V pacing, and I see this V pacing. And we have, could this be DDD? Could it be VVI? Okay. Could it be AI?
No, because it could have kicked in when you lost.
Would you have ventricular pacing in AI?
No.
No. So it's definitely, I mean, that's pretty straightforward. And how about DOO?
No.
No. Right. So here's your answers. Good. So yes, likely DD. It is likely. That's probably the most likely, right? Because you're A sensing and B pacing. VVI, yeah, it could be because maybe there's just a consistent atrial signal that's coming through, and then ventricular paces. AI, no, because right, you wouldn't have V pacing, and then DO, no, because it's not asynchronous. You have a continuous pacing there. So the reason why there's no P waves here is maybe they became junctional and didn't pick up anything, but the ventricular rate may be still just around when the patient needs to pace, and that's why it's going to give an output here. All right. So this is important to know, right? Because you're going to see this on the telemonitor, and you're going to have these variabilities, and people are going to tell you this whole alphabet soup of letters of DDD, AAI, VVI, and what this is, and what you may or may not see on the device. I'm sorry, on the tele. Okay. This was actually a C4 patient not too long ago. What's happening here? And what are we first seeing? What's going on in the very beginning? Pacing and QRS, right? We have a bundle, it's wide. So that's ventricular pacing. Is there atrial pacing? Yeah, it's a little fine, like it's a little hard to tell. There's a P wave like this one. Maybe that's it, like after that one there, that might be a P wave. But it's definitely not paced though. It doesn't look paced to me. And then look at this spike, and this one here, and this one here. What is that called? Loss of intermittent loss of capture. Exactly. Good. So it's not over sensing or under sensing, right? So it gives an output. So if it was undersensed, you would see a ventricular beat, right? And undersensed and still gave an output afterwards. So this is failure to capture. This is a patient that had a TVP, and we had to fix what are we fixing on this then? The MA, right? So you want to increase your output, right? So that would be something, TVP or epicardial wires. You can see this on either of those types of patients, failure to capture. You could see it on this too. I don't want to play.
I don't know what patient has a PA pressures of 71 and a CVP of 30.
That's, I forgot those numbers were on there too.
I was like, it's like this patient has a bunch of other things that they gotta worry about.
They had a whole lot going on. Yes, this was a lot of things going on. It can happen in this type of device too, an implantable.
DEF level 3 all clear. Facility alert, fire alarm, building DEF level 3 all clear.
So permanent devices can also sometimes have loss of capture for some of the reasons I mentioned earlier. Maybe the patient had an MI, maybe a lead moved, maybe there's a fracture issue, there's something else going on, that's why they're not capturing. So those are all things that you want to monitor. But typically for all of you, this is going to be your TVP or your epicardial wire patient. If they don't have output, you want to increase your MA. All right. So, all right. What's happening here? Okay, so let's forget about the first beat. Look at the second two beats. Paced, sensing. What do you got there? You got, well, afterwards, yeah, but the first two beats, that's atrial paced, right? It paces and you have a nice atrial contraction. That's why you see a P wave. And the QRS is actually nice and narrow, so that's their own rhythm, right? So if I looked at this, I would say, could this be AAI mode?
Yeah.
Could be. Could be DDD mode, right? It's not asynchronous, right? It's not AOO mode because you would just have pacing spikes throughout. So you have an AAI mode here, or you have a DDD mode here.
Can it also be DDI?
It could be DDI, absolutely, yeah. So it's going to inhibit, right, because they have their own intrinsic rhythm or native rhythm that comes through. But now we've got this. So we have two beautiful captures, and then we have some kind of wide, ugly-looking QRS complex that becomes much slower. Do you know what you think happened here? This gets a little tricky.
Is it loss of capture there, or is that just?
Mm-mm. So loss of capture, you're going to probably see some kind of output, and there's no actual capture. So there's no ventricular response. It does. So now it likely oversensed in this. It thought it saw something and then didn't deliver an output, right? So that's when you want to adjust the sensitivity and you want to make it less sensitive, right? Because it thinks it's seeing something that it's not. So let's just say the I'm going to use number 1. Say your sensitivity was at 1, go up to whatever the next is. I think these go like 1.2 and then 1.4 and then 1.5 then 2. just go up to the next sensitivity and see if it goes away, if it starts sensing properly. So remember, the higher the sensitivity, the higher the number, the less sensitive, to make it not oversense. If it's undersensing, you want to bring the number down and make it more sensitive so it sees it, right? Okay. Like patients who have wires in and they're in AFib, but then it's trying to give atrial pacing, because you said a DDD, but you see pacing and they're in AFib. It's not sensing the AFib. You want to sense the AFib. So change your sensitivity, right? Okay. This is my patient yesterday with an implantable, permanent device. I was like, the lady was ready to go. I got a phone call at 4:45. What was it, 4:30 last night? 4:45. Jen, there's pacing after this narrow QRS. And I was like, oh man, what's going on here? What do you think's going on here? So yeah, it's not the best, but look at the top. There's a really clear P signal. A P wave or atrial signal up at the top. You can see one here too. So it's sinus. It's in the 60s. See this little thing here though? It's a little, can you see that?
Yeah.
So it tried pacing right after the QRS. But there is a nice QRS, right? So what do you think happened here? It undersensed, right? So in the morning, everything was fantastic. Well, the ventricular signal was a measurement of, I think it was about 4.6. This is what we measure through here. When I went back, and the setting on the device, so 4.6, I think it was 2.8 millivolts, meaning that that window was not really double of what that, so there was a chance it was going to undersense just based on that setting, because the fence was a little bit too high. So I was like, oh, maybe I just need to change that. But then I went back and I remeasured the signal of the amplitude from the RV lead, and it was much smaller. It went from 4.6 to 1.9. I got an x-ray. The lead looked like it's still okay. I had the company check, because I'm here this morning. I have the company checking to see if they can change the polarity or the configuration on the device. I called the nurse last night. When I changed the sensitivity, there was no further episodes of this where it tried to pace. So this is an example of undersensing, right? So I had to make it more sensitive. So I had to make the number that was set at 2.8, and I brought it down to 0.9 millivolts, and that was on the implantable device. But this is something that you can see as well, whether it's through a temporary pacer or your permanently implanted transvenous system. I don't think I have too much left. Oh, I'm so sorry. This slide is really bad, but these are things you can see on telly. So the first one's AAI, whether it has rate response or not. So there is atrial pacing, that does say AP, and then V-sense, right? Because you're only pacing the atrium. So AAI mode, only pacing the atrium if the rate falls below whatever the set rate is. So AAI 60, if the rate is 50, it's going to pace at 60. This one is probably the biggest telemetry nightmare that we get calls about constantly. Because doesn't that look like there was like either a sensing issue or a capture issue there, right? Because there's no beat after this nice P wave. Well, in these lovely devices, both defibrillators and pacemakers, there is a mode. So remember I said we don't like RV pacing if they don't have resynchronization, because it could cause more heart failure, decrease cardiac output, cause more hospitalizations for heart failure. There's something called AAI to DDD or VVI mode, meaning that the device can naturally switch back and forth as it needs to between these. So this starts as an AAI mode. It's A-sense and V-sensing. Then in A-senses, there's no ventricular native or intrinsic response. That's why you don't see anything there. So then what it does, it AV paces. So now it goes from AAI to DDD. These devices do that because it's trying to allow intrinsic rhythm or native rhythm to reduce any kind of pacing. So if you saw this, you'd be like, oh God, the pacer's not working. Call Jen, Fran, or Shipra. What's happening here? But this could be a natural phenomenon from the device because of how it's set. All right. You can also see too sometimes that the PR interval might be 200, then you're like, why is the PR interval 280 and then 200 and 250? Why is it all over the place if it's a set interval? And that could be because of the same thing. It's allowing fluctuation to allow intrinsic rhythm. So there could be fluctuations in the PR interval. DDD, again, this is the same thing, switching back and forth. So between AAI, right? AAI, sensing, senses nothing, paces, senses again to see if there's any kind of intrinsic rhythm. There's not, and then it starts to pace as a backup. This would be coming out of this back to your AAI. So what happens is, see how short this pure interval is? See how long this interval is? It keeps prolonging to allow intrinsic rhythm. So this gets tricky, right? Because this all can affect filling times, like I mentioned before, too. So you got to be careful with this from our perspective about how much does the intrinsic weigh in for the patient hemodynamically versus having them pace all the time. So from an electrical perspective. So there's a balancing act with this. So it's really sometimes things that we have to tweak from time to time when we see the patients, especially in the outpatient setting and based on their symptoms. But these are things you can definitely see on telemetry with these patients who do have devices implanted. And this can happen in both pacers and defibrillators. All right, so why pace? Regulation of heart rate and rhythm, optimal diastolic filling, right? PRs prolonged, we talked about before, can affect hemodynamics. Short-term increase in cardiac output rate, increased cardiac output for the patient, especially in some of our surgical patients. Conduction delays, improved synchrony and conduction, our CRT devices or our bundle area pacing devices to improve contractility on the right and left side. And then, of course, somebody comes in, they're bradycardic, they pass out, they're dizzy, they're lightheaded, they don't feel well, and they have no reversible cause for their bradycardia or even sometimes transient heart block. We want to put a pacemaker in. Pacemakers also can reduce other arrhythmias, sometimes can overdrive. So somebody who has AFib, sometimes pacing them at a little bit of a higher rate controls the sinus node and prevents them from going to atrial arrhythmias, and then even cardiac arrest. Right. Oh, I'm done. Sorry, that was really long, wasn't it? Ooh, long.
Yeah.
Thank you. So show and tell. Thank you. Pacers, small, right? Don't need a big battery. I forgot the defibrillator. These are our leadless. Look at this nice little capsule thing, right? This is the sensor. This is the top. It's implanted through femoral up and dropped in the ventricle. The sensor at the top here is what drops in.